Okay, thank you, everyone. We're going to go ahead and get started with this teleconference. And I want to start by just thanking everyone for joining us today. My name is Victor Riches. I'm the president of the Goldwater Institute. And with me today is Naomi Lopez. And for those of you who may not know Naomi, she is our healthcare policy director at Goldwater. And we are extremely fortunate to have her. Naomi is widely regarded as the foremost expert in the freedom movement when it comes to healthcare issues. And she not only has the respect of countless policymakers and think tanks all across the country, but she's also in constant contact with federal officials, with Congress, and perhaps most importantly, considering this current crisis, with the White House. And we'll talk a little bit more about that in just a few minutes. And as everyone on this conference can probably relate to, those of us at Goldwater have had to adjust our thinking in the wake of the coronavirus. And for us, that thinking has really taken on three distinct prongs. Number one, how can we get people back to work quickly and jumpstart the economy once this crisis subsides? Number two, how can we provide better educational opportunities for families? And I really want to emphasize with this that I think this is particularly important considering the parents have literally been forced to bear the brunt of educating their kids during the past several weeks. And number three, what can we do to expedite getting patients the treatments they need, and not only during emergency situations such as the one we're dealing with today. And I'd like to focus in particular on this third component because the Goldwater Institute has long been at the forefront of healthcare freedom for many years, particularly with our Right to Try efforts. And for those of you who may not be familiar with those efforts, in a nutshell, Right to Try gives terminally ill patients access to medications that haven't gone through the full FDA approval process. And so what does that mean? Well, it means rather than wait for several years for a treatment, years, by the way, that these patients do not have, they can receive the treatment immediately. We passed Right to Try in 41 states in about a 5-year time period, and then ultimately at the federal level. And as of today, Right to Try has already helped countless patients suffering from illnesses ranging from cancer to ALS. And so, Naomi, I want to turn it over to you and ask you the first question, and that is this: what role is Right to Try and the concept of Right to Try playing in the current coronavirus crisis?
Well, the Right to Try is based on the important goal that the right patient get the right treatment at the right time. And I would say that because of the fact that Right to Try was passed in 41 states and at the federal level, there's been a lot of increased attention on what exactly that means. People understand and are watching the drug approval process and know that the federal government can no longer get a veto stamp on these very personal and important decisions when lives hang in the balance. So what does Right to Try mean today? What it means is that the public now has an expectation that probably wasn't there before and was probably dramatically accelerated because of the Right to Try movement, that there are treatments out there that are in the pipeline, and individuals who have run out of options should be able to access those. We're seeing this discussion play out in a couple of important ways. One, of course, is in the area of investigational treatments through compassionate use, which is an FDA pathway that's been around for a long time. Another way, of course, is through Right to Try. There are companies and manufacturers that will be providing treatments through Right to Try. And then there's also this issue of off-label use, which has been getting an enormous amount of attention lately. Off-label use is perfectly legal. Physicians have always been allowed to prescribe a treatment for an indication other than what the FDA approved it for. Now, we've been hearing it a lot for chloroquine and hydroxychloroquine, but there are also other treatments. For example, Genentech has a treatment called Actemra that's now in phase 3 clinical trials as a treatment for rheumatoid arthritis. And it is under clinical trial. It is FDA approved for a different indication, but it's perfectly legal for a physician to prescribe it if they think it's the right treatment for the patient and the patient is willing to take it, they consent, and then, and so we have a lot of different ways that people now have the expectation that there may be something else that might be appropriate for them if their doctor thinks that that's the right treatment.
Well, Naomi, you touched on an issue that I suspect is at the forefront of probably everyone on this conference's mind, and that is the discussion and the somewhat controversy surrounding the usage of chloroquine for the treatment of COVID-19. And I have to admit, personally, I do find the controversy somewhat perplexing, considering that there has been a number of doctor and patient testimonials surrounding the efficacy of chloroquine, particularly when you combine it with the Z-Pak. But can you tell us a bit about the work the Goldwater Institute has been engaged in around these types of treatments and how this crisis might actually change the way people think about, not only about, of course, chloroquine and treatments related to the coronavirus, but how this might start changing the way people think and understand off-label treatments in general?
Well, so Christina Sandifer and I have done a lot of work over the past couple of years on something called off-label use. And what that is there's an FDA gag rule that says that a manufacturer is not allowed to talk about the truthful and scientific applications of a treatment to physicians and insurers, except under a very narrow set of guidelines that the FDA has laid out. And so the reason that off-label use is so important is that off-label use is actually extremely common. About 20% of all prescriptions written in this country are off-label. If you have a child who's ever had an ear infection and had amoxicillin prescribed, that's actually off-label because the FDA has never approved it for use in children. If you have a complicated case of cancer, you probably have an off-label treatment. And the reason that this is important is because if you have a life-threatening illness, you don't have a decade to wait to find the best treatment for you. Your physician is more likely to know about it if they're at MD Anderson or Mayo Clinic or one of the other leading cancer hospitals in the country. Unfortunately, it's those patients in rural areas, those patients whose physicians may not make it to the big annual conferences every year where they discuss these kinds of treatments. And so the reason that off-label communication is so important is because your ability to make it to one of the nation's premier medical institutions for treatment shouldn't determine whether or not your doctor has that information that could possibly save your life. And it really does limit the physician's arsenal of what they can use to help treat you. Now, specifically in the COVID-19 crisis, the Wall Street Journal just wrote about this a few days ago, how a lot of doctors have just been one-on-one sharing information with each other through these informal networks about what dosage, what treatment, at what stage or progression of the illness does it work best. And so a lot of antidotes are getting traded. Unfortunately, these FDA gag rules really do limit what manufacturers can tell doctors. And that's a tragedy today because the people who need that information the most, those doctors who may not be, for example, at Henry Ford Hospital, where clinical trials with hydrochloroquine are going on today, may not know, they may not have the best information. And so that information gets delayed. And think about all the patients that potentially could have benefited from that. That doesn't mean it's the right treatment for every patient. It doesn't mean that a doctor is going to think that it's a good treatment for their patient, but they don't even know. They don't even have that information for something that is perfectly legal and, quite frankly, an obligation for them to provide the best treatment. Whenever they don't have that information, they just can't meet that obligation.
Well, and Naomi, I'll tell you something that I've always found offensive about the FDA gag rule that you mentioned was that not only does it do, of course, a tremendous disservice to patients and, of course, a disservice to doctors, but it's also a very clear First Amendment violation. And you know, Naomi and I only pretend like we're attorneys, but we have actually talked to our legal team here. And our attorneys at Goldwater feel like this is a very clear First Amendment violation when you have an element of the federal government going in and telling pharmaceutical companies that they cannot share these off-label uses with doctors. And so we have looked into this very extensively at the Goldwater Institute. I am very pleased to announce that this is an issue that we're going to be pursuing moving forward. And we think much like Right to Try, where we took a state-by-state approach, and much like Right to Try, this is an issue that a lot of times people have made the mistake of thinking this can only be done at the federal level. We believe very strongly you can take a state-by-state approach, address this issue at the state level, and actually apply pressure to the feds to change this gag rule and allow the free information or the free speech information between pharmaceutical companies and doctors.
And this is a bipartisan issue. This is not a Republican or Democrat issue. This is something that lawmakers on both sides of the aisle understand is a gag rule that hurts patients, and it hurts physicians' ability to treat patients. We've passed the free speech in medicine legislation in Arizona and Tennessee. It was passed unanimously in both states and signed by the governors. And this is, I think, a really important fundamental issue to signal back to Washington that patients don't want the government, the federal government, to have a veto stamp over their care.
And Naomi, for these types of issues, because when I'm out speaking with folks about this, they always ask me, why would something like this even exist? Is this as a typical antiquated bureaucratic rule that's been in place for several years? What would even be the rationale for doing something that seems so clearly to you and to me, and I suspect to everyone listening in on this conference, so clearly detrimental to patients?
Well, I think that there is a fundamental misunderstanding about who should practice medicine. And I think we're seeing this play out right now, in fact, across the country in these discussions around the right treatment for COVID-19. The idea that politicians would try to stand in the way of these off-label treatments, I think is the same thing with the FDA, where they have a fear that patients might get hurt. And obviously, there is potential harm in a treatment that may not be fully vetted yet. But the reality is that the physicians are legally allowed to prescribe it, and it is actually their decision in consultation with their patients about what treatment might be best. There are risks associated with any drug, but there are also a lot of risks associated with not having a treatment, not having the one that is best for that particular patient at their disposal. And so I think that there's this tendency to overregulate, this idea that you want to protect patients. Well, they're trying to protect patients by putting them in a cage. That's not how you protect patients. You provide the clearest, most direct, truthful scientific information possible. And that is what is being restricted right now. It is not, everyone knows that chloroquine and hydrochloroquine are being given to patients around the country, and some people have been taking it as a prophylaxis, particularly those frontline healthcare workers. And in fact, there's actually a clinical trial in Detroit where they are providing the treatment for about 3,000 frontline workers in this battle against COVID-19. What is not widely available is the information about dosing and at what stage it's been most effective. And that's why you have these informal networks of physicians trading information, trying to find out how they can help their patients. The reality is that having more clear information, having it be legal to share it, would do a lot more good than what this current approach is.
Well, and I suspect I'm not only speaking for myself when I say this, but I would much prefer that if I was suffering from an illness, for my healthcare decisions to be made between myself and consulting with my own doctor, rather than being made by bureaucrats back in Washington, D.C. Naomi, the next question I have for you, and this actually sort of relates to Washington, D.C. As I mentioned at the beginning, I know that you have been engaged in several discussions with the White House and other federal leaders about how to deal with this specific crisis. If you're able to share with us, What has been your advice to them, and what are you now working on at the federal level?
Well, at the federal level, quite frankly, I'm working on the same exact issues I've been working on for almost 5 years since being at the Goldwater Institute. So in dealing with the White House, there's been a lot of interest in the issue of supply-side healthcare reforms. Those reforms that would increase the supply of healthcare providers, out in the states. This is an area that state lawmakers have authority and, quite frankly, a duty to address. And so it's things like allowing certified registered nurse anesthetists to practice at the top of their education and training without the requirement that a physician has to be within the same four walls to do their job. It's also the idea that, and this is something that we passed a couple of years ago in Arizona, another reform that we passed in Arizona is allowing for mid-level dental therapists, almost like a nurse practitioner, but in the dental area. So it's these kinds of reforms that can increase access and affordability in healthcare, and it's governed at the state level. Now, the reason that this is tremendously important today, so those discussions have been going on for years, and we've worked with the White House on their reform efforts in this particular area. The reason it's particularly important today is because they are looking for ways to make these reforms permanent, but there's also a very strong interest on the part of the White House as well as the Department of Health and Human Services to free up healthcare providers so that more providers can help in the COVID-19 battle. And there are two big goals here. One is to limit exposure for patients going into the medical office setting and potentially exposing others to COVID-19, or those patients being exposed themselves. And so what you're seeing right now is a lot of innovation, a lot of changes in policy in the areas of telemedicine, for example, in the area of allowing medical professionals from other states to come into your state and practice in your state during this crisis. So these innovations under this crisis are actually accelerating, and I think that there's really an eye towards looking down the road to really understand how can we make these policy changes permanent? How can we make that something that states are already embracing these reforms during this crisis, but how can we make them understand that this is good policy all the time, not just in the middle of today's crisis? With telemedicine in particular, the Centers for Medicaid and Medicare and Medicaid Services, which is under the Department of Health and Human Services, has enacted some very important reforms that make telemedicine far more available for the nation's seniors. What I think a lot of people don't understand is that telemedicine is used for things like ICU, where a patient can be at their home and remotely monitored. They are ICU patients. They have video and audio feeds directly to the providers in the ICU, and it's two-way. And this is a way that someone can remain in their home and be in an ICU unit without actually having to be in the hospital, without actually having to be exposed to all of the other potential threats to their health, like infection, within the hospital setting, but also in a place where they might have someone who will take really good care of them too. And so these are reforms that are moving very quickly. They've been around a long time, but during this crisis, they're being accelerated through federal policy. As far as interactions with Congress go, there has been, since Right to Try, a lot of interest in things like reciprocity, where if there is a treatment that's already approved in a country that has a very advanced system like the FDA for approval, that scientific knowledge shouldn't have to be replicated for the FDA approval process. The manufacturer should be able to come to the FDA and say, this was approved in Japan, this was approved in Israel. Can you take a look at our findings and see if we can get approval here? So it's those kinds of reforms that are being discussed on Capitol Hill. And so I think that in this particular time, a lot of the work that the Goldwater Institute has been involved in over the years is now front and center in this particular healthcare crisis. The policies have not changed. The urgency for these policies has.
Naomi, you mentioned the idea of international reciprocity, which I think for most folks, it would seem like common sense. If there's been a drug that's been proved to be safe in, through a similar FDA process in Europe or Israel or Japan, why does it have to jump through those same hoops to be approved in America? And so I guess I would ask you, similar to my earlier question, is what is the reason why we still have these sort of antiquated FDA approval processes? Is this a sort of leftover provision from decades ago, or is there some argument that they try to make to say that we need to keep the status quo as opposed to getting these treatments to market as quickly as possible?
Well, this is certainly based on a decades-old approval process that really hasn't kept up with today's modern medical innovation. Think about a potential cancer treatment that is unique to your own personal DNA sequence. That was not around in the 1960s, but it is around today. And so this idea that you would still use the same approval process for something that's so medically advanced, something that, there really isn't necessarily a reason to go through 3 phases of clinical trials whenever we're just trying to find out if it's the right treatment for you. It's really not a very good fit. The other issue, though, is that there's a lot of risk aversion. The FDA is very much a culture that fears that something that's not safe could get out to market. Of course, there is responsibility on the part of Congress to basically say, look, we understand that it's risky, but we want you to do it anyway. And there have been a lot of good reforms over the years to get some acceleration into some of these treatments. But there's still that cultural bias against taking risk, and so that's something that we absolutely have to overcome. We're probably going to have to do it legislatively, and not just rely on FDA to use its full authority. There's a lot of reason to believe that they could do reciprocity today, for example, but I think it's going to take some legislative action to actually get them to move all the way in that direction. So we're working on these reforms, and I think, now more than ever, I think there's a realization that a vaccine that typically takes 10 or 12 years, keep in mind, there isn't a vaccine for MERS or SARS. Still, even though it's been several years, we are now talking about the possibility of getting a vaccine in, say, a year or 18 months. It's not that it can't be done. It's that because, when you have a lot of resources and a lot of urgency, it can be done in a year or maybe 18 months, perhaps. That would be the most rapid approval of a vaccine of this type ever in history. In the FDA's history, but it's essential. And so I think that with all the eyes on the FDA and the expectation that we just can't wait, I think that there is going to be a lot of pressure to continue to move treatments through faster, because we're now able to see the very real results of what happens when you don't have a good treatment, but when you don't have something approved. And very unfortunately, we've got a system that will test out a treatment in many cases using a control group, which means you're getting the standard of care, and then the group that's getting the investigational treatment. And in too many cases, it's just heartbreaking to see patients unnecessarily not get the best treatment for them in that particular case when their life hangs in the balance.
What is one of the things that's always been perplexing to me when we first started looking at Right to Try several years ago, we did a very extensive research project on it, and it was interesting to learn that those FDA processes that had been put in place around 1964, 1965 had very little change made to them. And when you think about all of the changes in society that have happened since then, the way people operate businesses, the way they conduct business, the way they communicate with each other, the way we receive commerce in this country, it is astonishing that in one of the areas that I would think most folks would say would be most important, and that is in healthcare delivery, that we really were still taking an approach, a 1960s era approach to a 2020 problem. So I think it's very exciting that there are some opportunities now beyond right to try to really take a very antiquated process and really bring it up to date with the rest of society in a way that can be massively beneficial to patients across the country. And Naomi, one other question I wanted to touch on, a topic I want to touch on with you before we open it up to questions from the audience is, it really does seem like society was genuinely caught off guard with the spread of COVID-19. And I have to admit, I find it astonishing how quickly a virus that originated in central China, literally hundreds of miles away from even Beijing, let alone other countries, could so rapidly spread across the world and become a global pandemic. And so I think the big question is what lessons do you think we should take away from this crisis to ensure we're better prepared if a similar event were to happen in the future?
Well, I think that right now we're still learning some of those lessons. But first of all, it's going to be that the federal government can't stand in the way of the right treatment for the right patient at the right time. You're seeing the FDA move faster in some areas. For example, vaccine development, they're moving very quickly there. But we know that whenever lives hang in the balance, they don't always move that quickly. And I think that that's something that will absolutely change going forward. Now, some of the other issues I think that we're going to figure out, and this is something that the Goldwater Institute is very involved in, is the alignment of policies at the federal level. For example, in healthcare, the federal government pretty much manages Medicare, Medicaid, and the Children's Health Insurance Program, as well as some other programs. But getting those in alignment, those particularly emergency powers in alignment with state policy, is something that I think there hasn't been a lot of institutional memory on. There hasn't been a lot of experience in those areas. In the area, for example, of getting the PPE into hospitals, that's another issue. How do you, this is, I think, something that's in large part under state authority. So I think that we're going to see a lot of different policies moving forward that will dramatically change. But I think one of the biggest ones is going to be allowing healthcare providers to practice at the top of their education and training, and the idea that you have to be able to scale up medical facilities very quickly, whether that's in the area of restrictions on the number of hospital beds the state has. Most states have these restrictions where you have to go to a board and ask for permission to expand your facility or to open up a new facility. That slows down the ability to expand capacity very quickly. So I think that a lot of these policies that are being waived today in this crisis are going to be the real lessons learned. These policies are often in place because the incumbents, the incumbents fear would-be competitors and restrict their access from coming into the market. And they always claim patient safety. Patients could get hurt, when the reality is that patients get hurt when you don't have capacity. Patients get hurt when you don't have healthcare providers able to respond quickly. So I think that we're going to see a really dramatic shift in this kind of thinking. We're going to be moving towards, I think, a new mental model that is going to be focused on the right treatment for the right patient at the right time. We've been seeing it evolving over time, but I think that we're going to see it become really entrenched going forward now that there's an easy way to demonstrate what these policies mean for patients who are in crisis and who need care today and who can't wait because their lives hang in the balance and they're running out of time.
Well, thank you, Naomi. I think I'd like to open it up now to questions from the audience. So I would ask that when you ask a question, please state your name before asking the question. And in my limited technological capabilities, my understanding is that if you press 6, it will open it up so that you can ask a question. So let's go ahead and open it up to questions from the audience. Thomas.
Yes, thank you so much.
We
It's
see
nice
you.
to be back. I didn't go anywhere, but it's nice to be back. First thing I just want to say, I'm so psyched to be here. Susan Gurman Goldwater is my father Bruce's first cousin. And I met Barry Goldwater III in Ohio. He's a great influence on me. I've been studying the family history and I've been following the Goldwater Institute. I'm so pleased to be here. I'm going to hesitate on asking a question for now because I feel I'm not quite as educated as I should be, but I'm taking it all in and I'm really honored. So thank you very much.
Well, Thomas, can I ask you, what is your experience? What are you finding in your community?
Well, I am a healthcare worker. I work for the Yale Program of Recovery and Community Health at my university, Yale University, where I also graduated from. It's part of the psychiatry department. We do a lot of community action. We work with at-risk populations, and these issues directly affect me. I guess my main question is that I support all of these repeals of outdated and outmoded legislature and conscription and policy. My real question is, do you feel that repealing such out-of-date legislation works better under state authority when states have accepted the changes or under federal authority?
Well, it's actually under authority of both right now. And so the federal government, as I mentioned, it regulates basically the scope of practice for providers and also a lot of rules regarding facilities. For Medicare, Medicaid, the state children's health insurance program. And so for psychiatry, for example, the Department of Health and Human Services several days ago came out with new guidance that basically says that they will align automatically without a state having to get permission from the federal government in this time of crisis to allow for more telemedicine under these programs in the area of psychiatry and mental health well-being, which is particularly needed today. But I think the other issue at the state level, they're the same issues where you have, for example, rules on, for example, counselors or mid-level providers who cannot practice at the top of their education and training. And so, there are a lot of rules around who can practice, when they can practice, where they can practice. And so I think that you actually have to have reform at both levels. And this is one of those lessons that I think states are learning very quickly. It's not enough to waive out of some of the federal rules, which actually the federal government made pretty easy, I think, right off the bat, and then took the extra step just a few days ago and said, actually, you don't even have to submit a waiver. We're going to give a blanket waiver, blanket authority, as long as it aligns with what's allowed in your state. And so you've really got to have the reform at both levels. And that's why there's so much coordination between the White House, the Department of Health and Human Services, and groups where there are health policy experts that help advise and help direct and guide the policies that they take. And that will continue because they're seeking advice now on where do we go from here? What's next? How can we make these policies more permanent?
And one thing I'll add to Naomi's comments. One of the things that we've seen when we're in times where it's not where there's not a crisis like there is right now. For example, when we were working on Right to Try, is that frankly sometimes going straight to the federal level can be a near impossibility. The United States Congress is not always super quick to act, particularly again in times where there's not a crisis on their doorstep. And so when it comes to issues like Right to Try and sometimes other healthcare issues as well, the best way of actually getting Congress to act is to actually start at the state level, create momentum around the country, because frankly, measures are easier to pass through state legislatures than through Congress, but get momentum going across the country and then take it to the federal level. And at that point, the feds are oftentimes forced to act on something that they otherwise maybe never would have.
My question is this. It seems to me like in order to do anything medically speaking, the environment we're in is one that is not permissive. That in order to do something, you have to have government permission to do it. How do we change the default setting? How do we give you enough money to change the default settings on liberty so that the only things that are prohibited are things that are demonstratedly dangerous and that you can do whatever you want to do without the government jumping on you with both feet?
Well, Charles, I guess I mean, it's a complicated question, but I do think that if there is ever an opportunity to really start going down that road, it is in the wake of these sort of crises. And one of the things that we've talked about a lot at Goldwater is this has the possibility of going one of two ways. You see the government right now, there's various executive orders and restrictions going on around the country. You know, most of them within some bounds of reasonableness, some of them certainly going too far. But we're seeing that. The flip side is, you know, we're getting a lot of requests from policymakers all around the country on what can we do to start eliminating some of these government barriers, whether it's to get a job, whether it's to get treatment, whether it's to get people into the educational opportunity they need. And I think the short answer to your question is it is incumbent on our side, on the Goldwater Institute and on the rest of our allies around the country, to make sure that when this coronavirus crisis has passed, we're able to really use it as a demonstration on why so many of these regulations were never needed in the first place. And when we're actually in a crisis situation, they prove to be detrimental. So I really do think the burden is on all of us to push our elected officials hard to actually roll back regulations in the wake of this, and not, rather than make some of these executive orders permanent or even pieces of them permanent moving forward.
And Charles, I think you've raised a really important point. This issue of individual and medical autonomy really is at the core of what we do in healthcare policy, whether we're talking about restrictions on mid-level healthcare providers from practicing at the top of their education and training, or we're talking about right to try. What it fundamentally comes down to is individual and medical autonomy. And one of the really exciting things about the Goldwater Institute and our work in this area is that, you know, I'm a policy expert. I work in healthcare. I'm not an attorney, but my colleagues are constitutional litigators. They understand the protections that the federal government, the federal constitution provides, and they also understand that the state constitutions can go above and beyond federal protections. And a lot of the work we do, a lot of the legislation that we've worked on, where we've been extraordinarily successful, relies on these state constitutional protections. And that is where I think the Goldwater Institute has an enormous value add to healthcare policy, as well as a number of other areas that we work on. But it's these state constitutional protections, like for free speech and medicine, the free speech protections in state constitutions is what drives our reform in this area. So I think understanding that our unique blend of expertise is policy and comes from constitutional law, federal and state constitutional law, and that's how we do what we do in a way that no one else does.
Hi, can you hear me?
Yep, we can hear you.
My name is Hannah, and I have been concerned about a lot of, I guess, just how quickly with the shelter-in-place orders they were to shut everything down, and now it seems like in California they're discussing maybe not opening things up until there's a vaccine or after the second wave, just different things like this. And you touched on this just briefly a little bit ago, but you've talked a lot about the medical side of things and changing the medical side. As far as like the economy side or businesses, you know, a lot of churches, there's been discussion about churches being, like in Kentucky, they were looking at the license plates and tracking everybody that attended a church, or protesters in California being arrested, even though they were following social distancing rules, things like this. Are you guys doing any work as far as, you know, what are our rights during a time of crisis? How do we make it harder for people to just shut everything down at the drop of a hat, things like that?
Well, the short answer is yes, this is an issue that we've certainly been looking at. In fact, we just had a meeting a couple of hours ago about this very topic, and it's been interesting to watch, because when you look at these different executive orders around the country. And of course, a lot of these orders are coming from governors, but there's also been a lot of actions at the municipal level, at the city and town level, that have even been more draconian than some of the gubernatorial actions. And there are certainly some states, and I guess I would say this, I think most states have been doing things that are reasonable considering the circumstances, but there are some states, and I would put California up at the very top of the list, and that happens to be a state that we were looking at this morning and that we are still discussing what the possibilities are there, that have gone way beyond the realm of reason and logic. So this is something that we're looking at, but I do want to stress, and we've had our attorneys dig into this issue pretty vigorously, that in states of emergency, executives do have a disproportionate amount of power to do things that they otherwise couldn't do. And it really is a shame that some of them, I believe, are taking advantage of that power. But that is something we're looking at to see if there are opportunities both to either roll that back during the time of the crisis, but even more importantly, to make sure that in the next crisis that comes up, they act in a little more reasoned fashion.
Wanted to go on with what the former questioner asked. I think we have been, the public has been subject to a lot of exaggeration and misinformation. I don't know what we do about it. I guess I sit here and I think the CDC dropped the ball early on. Why do we now listen to them? I mean, the numbers were based on prognostications that were based on computer models. We all know about computer models. What do you do about it?
Naomi?
So, Marcia, thank you for your question. I do think that there were a lot of missed opportunities early on, both on the part of the CDC and the FDA, and that's something that we are working on. Some of the reforms that we that we really that are really central is this idea of how much authority should the federal government have over our health, and so whenever we take a look at legislation moving forward, some of the ideas that are percolating right now on Congress, some of the bills that we're helping and assisting on, I think that you'll see that there's going to be probably more awareness going forward about the important role that states can play in things like testing, approving tests, for example, in a pandemic, in a state of emergency situation, and other types of approaches along those lines, where you're not, where there's going to probably be a move, not to take away a power and authority from the federal government, but more to have competing authority at the state level in the event of an emergency, where there will not be complete control from the federal government. If they fail to act, if they drop the ball, states will be empowered to go ahead and move forward and protect their citizens. And so I think that this has been, we're still very early in this crisis to really evaluate the full list of what possibly went wrong, what could have been done better. That will be for a later date. But I do think that the remedies are going to rely more on state authority moving forward.
Well, thank you. And I just want to, again, thank everyone for joining us today. We're obviously living in very unique and interesting and mostly unprecedented times. So we appreciate you all joining us for this teleconference, and we look forward to doing more of these, and we look even more forward to have the opportunity to get all of our supporters back together again in the very near future. So thank you very much, everyone, for joining us. Stay safe, and we will talk to you all soon. Take care.